to you, sir, and congratulations on award of PhD, and warm welcome to all of you, and happy Raksha Bandhan. And sorry at the time also this because we are keeping you busy pre-festival. So we are very happy and very lucky to have Dr. Rama Raju, sir. And Dr. Rama Raju, everyone knows he's a director of Krishna IVF Center, Visakhapatnam. And he has agreed to be with us for 6 months, and that's why we are just giving him the chance, and we want to take out whatever we can, and we can learn what most we can learn from him. Though I have studied your book also of individual stimulation protocols, wonderful book, and I really follow it many times in my practical knowledge also. And whenever I face problem, I really look for and refer to that book. Thank you very much, sir. And now I think we will not waste time. But our experts are there. I think Sharda ma'am is the one most punctual, most disciplined, and she is the one who joined earlier. No other expert is there. Sharda ma'am, you are too good and too respectful for me, for everyone who are here. And because of you, aapke karke hi sab kuch hai, ma'am. DGF is all because of you. And Dr. Rama Raju sir, ma'am has so many potential, so many good things.
I know, madam.
So I really welcome you, ma'am. Sharda ma'am, most welcome.
I'll just take 1 minute, sir. We all know that the success of ART cycle in most cases is directly related to the age of the woman and how many eggs you have retrieved. I must tell you that as far as my entry into IVF field has been very, very late. It was 2007. Sir, you will not believe, I went to everybody and I thought I had very close friends. But when it comes to sharing the protocol, when it comes to sharing what all you require as an equipment, and even telling what are the drugs are you using, nobody is going to share with you. And what I found is everybody said that you will not be able to do IVF training program. I said, okay, Dr. Raju's training may be 100 times, but I'm sure I will do a good job as for the basic training part is concerned. And I find, now nobody can say कि कोई protocol नहीं बताता, कोई ये नहीं बताता क्या drugs use करते हो, कोई ये नहीं बताता कि क्या आप consumers लेते हो. All that kind of things we do. But I still tell you, what is the problem as far as the ART experts in this particular country are concerned? They will talk what is happening in Israel. They will talk what is happening in America. They will never share what protocol they use. And that is why we all are confused. And I think, we are all doctors, but we are also scientists. If there can be a protocol for eclampsia, if there can be a protocol for PPH, why can't we have a protocol for ART cycles? And I think, top 10%, 20% you leave for, the specialized, individualized protocol. But in 80%, we should be able to follow it up. Ye hoga to ye karenge, ye hoga to ye karenge, ye hoga to ye karenge. And sir, my sincere request to you in the end also is that that your things which you do it for Poseidon 1 and 2, those investigations, we must have a lab here which gets connected here so we can send our samples to your place. So that particular part also you need to work it out. Over to you, sir.
What you said is absolutely true, but there is a difference. When you look at oncology in 2000, it was same as IVF was today. Every clinic in the world in oncology used to have their own protocols. And when something new came, they jumped in and started the protocols. But it's not so now. Oncology around the world have standard protocols. And the newer protocols, they use it in specific situations in relation to the risk-benefit and the cost-benefit analysis. That is where in Comparative medicine, where there is no protocol that universally accepted protocols, because our leaders never insisted and copied the good things from the oncology society. In oncology society, wherever you go, the first line of treatment for ovarian cancer is the same thing. The recurrence is the same thing. The monitoring tools are the same thing. If a new drug comes on the street, they don't change the first line of protocol. But that does not happen in reproductive medicine. we just jump what is fanciful, what is glorious to tell that it gives a better result, even though we don't believe it. So our attitude and opinions should change and follow the lessons oncology societies around the world have developed and learned. We should not wait further long to make the same mistakes oncology did in 2000. Even in the area of research, we don't have causes. Oncology are not able to use genomics to say this is the cause for this group of cancers. And we are at the same point where we started in 2005. The science has not changed, but we have not integrated the developments that have come in other fields into reproductive medicine. Oncology has did that. That's the reason life expectancies have improved. And now you see a whole generation of people with need for fertility. That's my personal opinion. And that's where we should look at it. In this
So make it full screen.
you are able to see my screen now?
Yes.
I brought my slides.
Yes.
Nice. Here, what I'm doing is, I've taken the current scientific evidence that is there in different stimulation protocols and walk through you those stimulation protocols and what exactly I use in different stimulation protocols. That is the purpose of this lecture. I'll be basically covering the previous common protocols for all women and now how it's being individualized. What is the polycystic ovary woman and role of antagonistic protocol and how we do it? The Poseidon 1 and 2 categories. What are the changes that are happening in normal responders? What is the evidence of newer evidences that are coming in poor and hypo responders? And then newer guidelines of treatment protocol. But I'll stick to most of the time what I do in our clinic and what is the current evidence. The first thing is, after decades, we have realized that one size does not fit all IVF stimulation protocols, and individualization is the key in reproductive medicine. But this concept of individualization, we miss the main concept that individualization is for a group of diagnosis, not for every individual patient to the micromanagement. You can do micromanagement in certain situations, but your individualization should happen in different groups. Essentially, when I mean different groups are, one is a normal responder, an older patient, a poor responder, a hyper responder, and in the role of fertility preservation. These are the areas where individualization is being spoken about, and we try to get confused that every protocol should be individualized to the every patient, but it's for a group of patients with a common BMI, common age, and a common antral follicle count, and a common demographic data of the patient. That's how we should individualize. So when we look at the data, when we say personalization of treatment, we personalize our treatment and group them based on the following thing. You have an young patient, a middle-aged patient, and an older patient. We individualize the age into less than 25, less than 30, less than 35, and less than 37 and 40. Based on that, we give the dose of FSH. Similarly, we use a combination of either the antral follicle count or anti-Mullerian hormone, but not both. We at the clinic, even though we do AMH, we essentially base on stimulation protocol on antral follicle count. We divide them into 3 groups: less than 8 antral follicles, 8 to 16 antral follicles, more than 16 antral follicles, and more than 30 antral follicles. And based on that, we give the FSH dosage. Suppose a patient with an antral follicle count of 8 to 16, we can have a standard dose of 200 units and then reduce it if the antral follicles are more, and further reduce it if the antral follicles are very high. Similarly, if the antral follicles are lower, you might increase the dosage, but the total dosage is never crossed 300 units. Similarly, earlier we used to use the FSH and the CC challenge test, but almost it's more than 5 to 8 years since we have given up FSH. We also look at the notes of the previous ovarian stimulation response, if it is available, and look at whether the dosage was uniform, whether how many eggs were obtained as per the scan image if they're available, and then look at whether there was a problem with the follicular oocyte output ratio or the follicles have not come up properly. We also give a lot of importance to BMI. We take a BMI of 25 to 30 as normal, even though the British says you should take for Asian population 25. We take 25. If the BMI is lesser, we reduce the dosage by 25 units. If the BMI is more, we add another 25 units. If the BMI is 35, we add another 25. That means compared to basal level, the BMI is 35, we give close to 50 units more. Similarly, if there are collagen disorders with active disease recently like psoriasis, collagen disorders, Crohn's disease, where we add 25 units more than that because they are associated with suboptimal ovarian response. So the starting dosage, we use a combination of age, BMI, either antral follicle count or anti-Mullerian hormone. Then we also look at the immunological and the health issues, and based on that, we give the starting dosage. This is called adequate FSH dosing. When you give adequate FSH dosing and then you get suboptimal response and you see follicles that are there that are not going, then the concept of hyperresponder to the Poseidon concept comes into play. The goal of any ovarian stimulation is, one is we should get adequate number of oocytes, we should avoid hyperstimulation, and we should minimize the risk of hyperstimulation. Nobody can say their hyperstimulation risk is 0 because when you look at the whole concept, you are doing an ovarian hyperstimulation, and in that ovarian hyperstimulation, we are added a word control ovarian stimulation, but never defined the individual dosage studies were never done for different responders. So when we look at and say that we should have adequate number of oocytes, we should avoid risk of cancellation. the risk of OHSS with optimal dosage is important, but more work is needed to make a zero ovarian hyperstimulation clinics unless further development comes in understanding the cause of ovarian stimulation. One of the things we do is, once we have a starting dosage, we don't change the dosage unless we grossly feel we underestimated the dosage. The second thing is, we generally don't increase the dosage of gonadotrophins. The reason is, on the 5th or 6th day, if you are doing without any genetic polymorphism, if there is follicles are seen and then the growth of the follicles are not happening at the right place, this is where you add LH. This concept is called ongoing hyperresponder. The concept of ongoing hyperresponder is, you don't land up in a problem and then say, I had a hyperresponder. You identify when it is happening and then identify and add LH dosage. So the concept of addition of LH product happens in two situations. One in the classic Poseidon 1 and 2, where there is a previous cycle information, or in the current cycle, if you are given adequate dose of FSH, and then you are seeing the follicles on ultrasound, but the progress and the ET are not growing, that is when you add the LH. The other principle we use is, we don't change the products, we stick to one product. I don't say one single product is the best product, but each has its own merits and demerits, and use a single product in your clinic, and also insist that the batch numbers are similar or only known batches are there. When you analyze a failure, you can go back and look at the batch numbers of the patient and see whether you use products from multiple batches or single batches. If you give brand loyalty to any particular company, they'll be able to give you only 1 or 2 batches so that you have consistency of the product. The other important thing when it comes to gonadotrophin is see that the cold chain management is perfect, be it at the point of the depot, at the point of the transfer, and your own clinic. In your own clinic, it's prudent to have a temperature monitor of your fridge and ask the people who is monitoring that product to maintain a temperature log so that you know at what temperature your products are stored. This makes a huge difference. Then you have a cutoff level of, when you're using an antagonist protocol, have your own cutoff level when you want to do HCG, when you want to do GnRH, when you want to do a combination of GnRH and HCG, and then that cutoff level should be based on the following criteria. One is, are you using a freezing all protocol, or are you using a fresh cycle? We at Krishna IVF routinely use only a fresh cycle protocol. The other important thing at ovulation trigger is how much of GnRH or HCG you're going to give to a patient. And also the important thing is where you're giving the HCG. If the woman is obese and has a lot of abdominal fat, if you give your HCG on the abdomen, then you might end up injecting the drug into the fat and the absorption profile does not happen properly. So the policy we adopt at Krishna IVF is, we give the medication on the arm if the BMI is more than 30 so that we are not injecting into the fat tissue and in turn land up in a situation of an empty follicle syndrome. When it comes to a luteal stimulation, we have adopted a new protocol for the past 1 year, where on the 4th day in a frozen cycle, we are measuring the progesterone values. And if it is a crinone gel, we expect a progesterone level of more than 9 nanograms. And if it is less than that, we cancel the cycle and start with a higher dosage in a subsequent cycle. But this protocol we don't follow in in a fresh cycle, but this is what we follow in a frozen cycle. In other words, in a frozen cycle, our protocol is very simple. We give 3 tablets of Progenova from day 1 or day 2 and ask the lady to come on day 11. Day 11 as a cycle. We do an ultrasound. If the endometrium is triple line, we also look at the cervical secretions and then start the progesterone. The one which we use now is the Crinone gel. And on the 4th day of Crinone gel, we measure the progesterone levels. If it is more than 9 nanograms, we do the embryo transfer on the 5th day for a frozen transfer cycle. If it is less than 9 nanograms, we cancel the cycle, or the literature says you can shift to the parental progesterone and measure the progesterone the next day, but we are just cancelling the cycle and planning it at all in the next cycle. The other thing which we do when we do a protocol is we feel in IVF we should always have a diagnosis, and based on the diagnosis follow the protocol. And seldom, most of the time what we feel is ovulation stimulation protocol, an ICSI or an IVF, and you have an embryo, that will solve the problem. But it will solve the problem only to a certain extent. We should do a comprehensive workup from the medical history, the physical examination, the ovarian reserves, the dysfunction, and then come to a diagnosis, and based on the diagnosis, plan your approach to stimulation protocol, which will lead better results. In the area of polycystic ovary, there is a lot of controversy, but this controversy is resolving with the onset of antagonistic protocol. In antagonistic protocol, we start the protocol, the dose of the FSH based on the criteria which I said is age of the patient, body mass index of the patient, the number of antral follicles that are there, the coexisting antithyroid, antimicrosomal antibody levels. If they are very high levels, we give a different dosage. Coexisting health conditions, like if she is a diabetic which is needing insulin, her requirement of FSH is slightly higher than compared to women without diabetes with the metformin. Then we also exclude that the thyroid is well corrected and the prolactin is taken care of before we plan the stimulation protocol. One common thing which we do while we are dealing with polycystic ovary syndrome was we make sure that the diabetes is well controlled and the candidal infection is eliminated, because lot of times I see prescriptions when people give antifungal agents during stimulation protocol, and these reduce the estradiol levels and give a false sense of security there. And also it has an effect on the oocytes. So we make sure that we don't give any antifungal agents during a cycle regime. That is one precaution I would like, because most of the time we don't give much importance to that. The protocol we follow is earlier we used to do even for the long agonistic, for the polycystic ovary, we follow the long protocol using the receptor polymorphism. But in the past 1 year, we are slowly moving on to only antagonistic protocol for PCO women. But we are giving a combination of GnRH and HCG 1500 units for the induction of ovulation, and then we are doing the fresh embryo transfer cycles, and we are quite comfortable with the results. The role of polymorphism comes in polycystic ovary in a LH receptor, where you see women with polycystic ovary women, and if they have an LH CGR polymorphism 312 A by A pattern, that's the woman where they don't need LH supplementation. These are the women who are more prone for hyperstimulation, and these are the women who need careful monitoring an accurate dosage. When it comes to hyper-responders, we should always have a clarity between a poor responder and a hyper-responder. Lot of times, we fail to understand these concepts, and a poor responder is like a shallow well, and how much or deeper you dig, you won't get anything. Whereas in a hyper responder, it's like a deeper well. If you plan your protocol well and give optimal LH supplementation, then you get adequate number of oocytes. But the hyper responders, which we see every day, we are looking at only good hyper responders, but we should also give a lot of importance to the hyper responder of an younger woman and the hyper responder of the older woman. That means giving importance to the age. Similarly, in hyper responder, also giving importance to the body mass index, which we seldom do, and none of the Poseidon concepts, like publications that are coming in, emphasizing the role of the age. And looking at the recently, I discussed with after the publication of the last paper. He said that the LH polymorphism, gene polymorphism, in future might redefine the concept of Poseidon and where to do LH supplementation. Because one thing when you realize about Poseidon concept is, in a Poseidon concept, already a cycle has happened and we are looking at a second cycle and planning a treatment. When you use the genetic polymorphism or the concept of ongoing hyperresponder, that is where you will be avoiding a cycle wastage, but at a cost of a receptor polymorphism. So I repeat it, like if you use receptor polymorphism to understand gonadotrophin receptors, then you will avoid a hyporesponsive stimulation. Thereby, your need for Poseidon classification in the second cycle is minimized. But if you already have a previous cycle information, and when you look at the charts and look at the AMH and the antral follicle count, and when you find group 1 or group 2, that is where you can give LH supplementation right from the beginning. And in group 3 and group 4, in group 3, there is a certain amount of role of LH supplementation. And in group 4, there is very few role of LH supplementation because they are quite low in reserves. And this is the current situation. In a hyperresponder, what happens is, if you have this many follicles and if you stimulate properly, you get adequate number of follicles. That is where your stimulation protocol is efficient, also known as oocyte number to antral follicle count. If you do a proper stimulation, you get a good response. And the variabilities that can cause this are inadequate dosage of your FSH, genetic polymorphism. The third thing is playing with the FSH or the follicle stimulating hormone dosage too many times, so that in the process you are fiddling with the follicular development. The second thing is the quality issues, your HCG dose administration, and the efficiency of the oocyte pickup. All these make a difference in hyperresponders. In a normal responder, what happens is, whether you use an agonistic protocol and an antagonistic protocol, it really doesn't make a difference. And we, for a normal responder, invariably use the long stimulation protocol. The reason why we use the long protocol is, one is you can time your cycles better. Second thing is, you need not rush and start the cycle on a first day or second day or on a weekend without doing your proper homework for the woman. The third is, you can schedule your cycles so that too many cycles do not come in on a single day. And then the woman is in the bleeding phase, so she is more comfortable to come to the clinic, and then she is not at any disadvantage. That's how we look at the role of long stimulation, long down regulation and normal responders. Ultimately what we see is, whether it's the new antagon protocol or the old agonistic protocol, ultimately depends on three things: what you're comfortable in your clinic, what your patients are comfortable, and what is your organization comfortable in deciding a protocol, so that you get optimum oversights with better quality and care. This is one chart which I find useful in my clinic, where I use the AFC, but generally I also use this value to see whether it's collaborating with the AMH values. And at this dosage we give 200 units, and at this dosage we give 150 units, and at this dosage of 20 antral follicle or more with a lower body mass index, we might reduce our dosage to 75 to 100 units. That's how we do the dosage, as mentioned in the beginning of the talk. An evolving concept is coming in for the role of GnRH agonist for poor and hyper-responder thing. For a hyper-responder, after the advent of antagon protocol, what was realized was your stimulation protocol in a hyper-responder should start as early and as close to the day zero of the cycle, or in fact, there are proponents who start their stimulation in the luteal phase, so that the follicles are not selected into dominance before you start your FSH. And now, again, a lot of studies are coming in which shows a long agonistic protocol is being helped, and says it gives a better quality oversight, even though it does not change the numbers in poor and hyper responders compared to the control groups, that is the antagonistic group. But we have been a long time using for hyper responders the long protocol. For the poor responder, either we use a long protocol but increase the duration of downregulation to 3 to 4 weeks instead of 2 weeks, so that the LH suppression is too much. That's the protocol we follow at our clinic. And this is one article that's interesting to read, where they have come up to the publication on the in 2018, where they given long agonistic protocol compared to antagonist in decreased ovarian reserves, and they have studied both the HMG and the FSH in different publications, and found that the oocyte yield and the pregnancy rates were better. I would request all of you to go through this interesting article, which if you don't have it, you can write to me. I'll send a copy of that article. Just like as I described in hyperresponder with the polycystic ovary, what we look at is, compared to what is described, in addition to that, in some of these women, we routinely measure testosterone levels, and if the testosterone levels are higher, we find that when they need much lower dosage, and dosage similar to a polycystic ovary, if you are having a regular cycle woman, with no significant acne, with higher testosterone that is closer to 75 nanograms, that's where we reduce our dosage to much lower levels. And we also look at the FSHR 680 polymorphism. If it is a serine variation, and N is also a short name for amino acid asparagine, which is converted into a serine. These are the people who produce a hyper responder. Since we also do FSHR responder, in these women, we try to reduce the dose of FSH and minimize the risk of hyperstimulation. This is in the area of FSHR receptor. And here is an interesting study about the role of body mass index, which I was describing based on the BMI and based on your antral follicle count. Giving importance to BMI makes a huge difference, and we adjust our dosage by using a combination of antral follicle count and BMI to give an optimal stimulation. Here you see a woman with 50 kgs with a higher amount of antral follicle count, more risk for hyperstimulation. Whereas here you are seeing a woman with 80 kgs, the risk of hyperstimulation is minimized. So based on this study, individualized body weight, the risk of AOH is reduced by using individualized dosage, as most higher body weight values are in the left lower quadrant, that is low birth weight and low HSS. They result in less probability of live birth rate. So adjusting your dose not only based on the age, AFC, but also based on the body mass index will help you to give a better individualized stimulation protocol. Regarding dual stimulation, I don't have much experience. I just brought in some of the slides that are there. One is a random stimulation protocol where it started on the first day, and then after the egg retrieval, a couple of days later, the stimulation is restarted again. But in this protocol, the woman will have bleeding, but the stimulation can be continued. In the second protocol, what they do is they do it on any time of the cycle, and then after the egg retrieval, they start the second cycle. So the first ovarian stimulation can start randomly during the menstrual cycle, and the second can begin any day after the first oocyte retrieval. This will be useful for the ovarian cancer patients. And this is the upper protocol is being used for the grower protocols. And one more concept that is coming in is the use of progesterone as a down regulator, because medroxyprogesterone decreases the LH significantly. And in the last couple of years, there are a lot of protocols coming in using progesterone or progestin primed down regulation, not down regulation, because it reduces only the LH, and then doing the stimulation. This is an interesting concept that is coming in. So based on that, I would be open for any questions. We start with the questions using the normal responders, then we go to hyper responders, then we go to the poor responders. If you go that way, it makes me comfortable.
Thank you very much, sir. Very interesting and very elaborate lecture. I invite our experts of the Dr. Sharma is there. I don't know. Dr. Sunita, welcome. Dr. Sunita Arora. I really invite all experts to comment on the topic and if any queries are there. So Dr. Sunita, it is your turn.
Thank you, Dr. Seema, for having me. Thank you, sir. It was a wonderful talk, and I think it was a treat to listening to you. Sir, I have few things in my mind, like this. One is this progesterone primed ovarian stimulation, which we are hearing about a lot, and few patients have been tried on also, but do you have a practical experience of the quality of oocytes in such stimulations?
Generally, what happens is we don't change our protocols just because it has come in. That's first thing. Second thing is, when something is working good, the data should say that the next drug should be better than the existing drug. And I didn't find the evidence that it is better. When you look at the approval of new drugs in the area of pharmacology by the FDA for licensing for phase 2 and phase 3, they say it should be better than the existing drug and more safe, and that's how they give the approvals. But unfortunately, in reproductive medicine, be it the gonadotropin receptor, GnRH, be it FSH, or the HMG or the HCG, we never had drug approvals for them. They were used into mass circulation before they were realized that they have action. That's what I feel. Even when we look at ICSI, by the time the procedure was regulated by any authority, it became a well-versed accepted procedure.
Please mute yourself. Please mute yourself, all of you.
So when you put your question of progesterone as a down-regulation, I'm not using it and I don't intend to use it in the next couple of years unless it shows a significant difference of safety and better oocytes and long-term better benefits in the outcome. That's how I would look at it.
Okay, sir. And my second question is that for deciding on fresh transfer cycles, so do you do progesterone levels on the day of trigger? Or you just go by 4 days progesterone and measuring the level, and then if it is okay?
In a fresh cycle, we don't measure the progesterone. Whatever I was discussing was for the frozen cycle.
Frozen embryo transfer, okay.
In the fresh cycle, we get confused between premature elevation of progesterone and premature luteinization. That's a key concept. Lot of times, many of us were not taught the difference between premature elevation of progesterone and premature luteinization. In premature elevation of progesterone, there is a subtle elevation of progesterone which is in the range of 0.5 to 1.5 progesterone. Whereas in a premature luteinization, it's a progressive rise of progesterone leading to premature luteinization. And the second problem with the premature elevation of progesterone is, if it is to be accepted, it should be done by mass spectroscopy, not by the chemoluminescence method. Even the stimulation protocol guidelines that were given by the SRA say if you are using the progesterone for estimation for deciding the embryo transfer, you should use the estimation by a mass spectroscopy. The reason why I'm saying is the sensitivity of mass spectroscopy ranges from nanograms to picograms, whereas the conventional chemoemulsions method, the sensitivity stops at 0.3 to 0.1 nanograms. So we are measuring the progesterone that we are using at the lowest range of the sensitivity of the machines, and in that process we are having a lot of errors. And if it is an NABL accredited laboratory where you're getting the progesterone, ask them a concept called variability of your test. Because in NABL there's a criteria where you can ask an NABL accredited laboratory which is certified for progesterone, what is the variability of their progesterone? The meaning of that is, if they run 3 samples of the progesterone, how much of difference they are seeing in the same product. As an end user or a clinician, NABL gives that right of requesting an NABL certified lab of asking the variability of their test because they are supposed to maintain the data. But the final answer is, we don't use progesterone because a significant number of cycles are long protocol. The second thing is, we are not comfortable with the concept of the premature rise of progesterone because we also look at the endometrium and also the junctional zone changes in the cycles which we transfer. So my answer is we don't at all use progesterone. And even though we want to use it, we'll be only using it by LCMS method. But by the time, what I see is, these are the women in which we see a progesterone are the persistent over responders where you have an adrenal excess component. Those are the groups who can have a progesterone rise. Whereas in a poor responder, a progesterone rise can also happen. The other important information that is here is the progesterone levels you use for day 3 transfer, the cutoff levels, and day 5 transfers are different. The fourth information is progesterone levels and implantation of a blastocyst varies between a day 5 embryo and day 6 blastocyst. So these are the variables we are never thought of and we never considered when we use progesterone. So in summary, your progesterone, if it is elevated, are you using that value for a day 3 transfer or a day 5 transfer? The cutoff levels are different. The second thing is the progesterone rise persistent for more than 3 days? That's the second thing. The third thing is, are you using a blastocyst which is a day 5 embryo or a day 6 blastocyst? Then it also makes a difference of the progesterone value. So it's not a simple value. And the fourth and the last and the most important thing is asking the lab which is providing you the progesterone, the variability index of that particular test needed for that progesterone. And if the variability is very less, then only use that lab for progesterone estimation. Otherwise, use an LCMS lab which is able to give you the report on the same day. The problem with LCMS labs are not every of them run the test every day. So you might have a lag issue there.
Okay, sir. Thank you. Thank you so much.
Thanks.
So, Dr. Seema, do I have time to ask just one more question, or we want to move to other chairpersons?
Because this is the purpose of the whole thing.
Sir, in polycystic ovarian cases also, you said that you go ahead for fresh embryo transfer. So then what is your criteria? Like, is it the number of eggs? Is it E2 level? Or do you always, as a blanket, always try fresh embryo transfer also by giving 1500 HCG, which you mentioned? Or there is some criteria where you will freeze all and do a frozen embryo transfer?
The first thing is, I would ask one question. Why are you adding multiple variables to an existing process? In a freeze-all protocol that has come in because there's a problem with the luteal support. And if you're able to take care of the luteal support adequately, one is by supplementing LH or measuring the progesterone multiple times. And your goal there is to avoid hyperstimulation by the induction of ovulation. And when we are, the second thing is we also have a policy of looking at we routinely do only fresh embryo transfer cycles. And in the frozen embryo transfer cycles, you're adding a variability of an accident. And you're adding a variability of a documentation. And for some time we thought we'll use the frozen transfer cycles, but after there's an accident in US in 2018, which was last time discussed, where 4,000 oocytes were lost by a Cleveland clinic in Ohio. There, the people are going to case as homicide. Why do we want to bring headaches to the existing headaches in this field? But we are comfortable with doing fresh transfer cycles, and we didn't find any difference moving to further number of transfer cycles, except making the things complicated. The only advantage I saw was the counseling becomes easy when the result comes negative with a frozen cycle compared to a fresh cycle. That's the only difference I see.
Thank you very much. Thank you, Dr. Sunita. Dr. Jyoti Malik, ma'am.
Jyoti Malik, Jyoti Bali,
Sir,
Jyoti Aggarwal.
Sir, I would compliment you for this lecture of yours. It was very extensive and very eye-opening, though we keep doing it every day, but there was a lot of new insight into it. My question to you would be, sir, for poor responders, are you using AACP protocol? That is agonist conversion to antagonist protocol. Priming with agonists.
In a poor responder, I divide them into based on one is the age, less than 35 and more than 35.
Right, sir.
Then the second thing is I use the long protocol, but I increase the gap between the stimulation protocol, gap between the down regulation and the stimulation protocol to 4 weeks, so that my down regulation is very, very weak. And I also measure testosterone in them before I start the cycle. And after give them HGA, if the testosterone levels are lower, 3 months before I start the cycle. These are the precautions I take. Regarding the stimulation protocol, I never cross 300 units. And regarding the LH supplementation, if there is a polymorphism, then only I give the LH supplementation, and I don't give the growth hormone. And the only other thing in a lower responder is my HCG dose might be higher than conventional people.
And so using microdose flare for the poor responders, is it any better than these other protocols for poor responders?
We didn't find any difference, so we stuck with this protocol. When you look at your down regulation and then give a gap of 4 weeks, how is it different from microflare? You hardly have, you're basically, your goal in any down regulation is to prevent a premature LH surge.
Correct.
And an excess response might increase the dose of FSH. So if I give a longer gap, my purpose is served.
So fresh transfer versus frozen transfer. We've always felt that frozen transfer gives us 10% higher results overall. So what is your experience with, because you said you're doing a lot of fresh transfers.
The difference is when you freeze and thaw a cycle, an embryo, and it survives, it's a better embryo.
Correct.
And that means you're screening those embryos.
True.
That's
Why
true.
don't we think that way?
Yes, sir.
Agreed, sir. We've switched over. Mostly our cycles are mainly FET cycles. We've really brought down the rates to, fresh cycles are hardly any numbers that we do in our clinic for a very long time now.
But you should look at this way, oocyte to pregnancy rate. And oocyte to pregnancy rate and number of extra frozen embryos that are there. That gives you the real quality of your stimulation protocol.
Correct.
I would say how many extra embryos you are having.
Thank you, Dr. Jyoti. Over to Dr. Jyoti Malik, ma'am.
Yeah, thank you, Dr. Seema, and I should just thank Dr. Sharda Jain, ma'am, because I could hear something out of the world today, out of the world, sir. Because you are doing what we are not doing. You are doing something which everybody is not doing. You are doing fresh transfers. You are doing long protocols for the poor responders, and you are doing so many micro details. You are doing, sir, if I got you right, you check for antimicrosomal antibody levels.
Yes.
So how should we do those, in which particular cases, or it should be done in all cases, and what is the logic behind doing that? Number one. Then secondly, you've spoken a lot about the receptor polymorphism, LH and FSH, and you've been doing FSH 680 polymorphism, tests also to find out about the polymorphism in those receptors. So how do we go about those tests? How costly they are? In which particular cases only if the eggs are not growing, and if we see that if we've given enough of FSH and we've got stuck at 14 then we should be doing these tests, or we should do it in the next cycle. How should we be? These are something, 2-3 things which are very, very new to me. I was really ignorant about these. How about these tests we should be doing? Then another very important point that I learned today was that even in diabetes, if a patient is suffering from diabetes, we have to still think of checking our dose. How much maybe we should be giving a little extra gonadotrophins in those particular cases. So that was something, so many points I have learned today. The variability of the test that you are talking of in a case of progesterone, that in particular lab, we just get the progesterone levels done and we don't bother how they are being done. You have suggested mass spectroscopy should be the ideal method rather than the chemiluminescence method. So many small little points I have learned today. I am really grateful to you and Sharda Jain ma'am and Dr. Seema so she could make me join today, and I would want the answers now, sir. Thank you, sir.
I start with the last thing, the diabetes. When I speak about diabetes, I'm speaking of the patients who are on insulin with diabetes. I'm not speaking about the patients on metformin and diabetes.
Okay, sir.
A patient with diabetes, which a significant higher amount of insulin requirement, there the dosage of FSH is different. That's one thing. The second thing is, should you shift off to polymorphism immediately? The answer is no. The reason why is, unless you understand the management of hyperresponder and do it efficiently, then you can get the benefit of the polymorphism over and on top of it. The reason is as such. Whenever you start a stimulation protocol, write on a separate paper how many oocytes you are going to get. And you will have lots of shocks and lot of learning experiences.
हाँ बेटा रिमाइंडर भैया को पकड़ा दो कि ठीक करने दे दें सुमन को दे देंगे 6 है ना बता देना 6 है बेटे
Dr. Jyoti Bali, please switch mute your mic, please. Thank you.
So what happens is, if you write it on a separate piece of paper, you don't have legal issues. And then look at the end of the cycle, did you pass or fail, not the patient. The second thing is, then on the 4th day or 5th day during stimulation protocol, we blindly look at E2 levels or the follicles. We never look at cervical secretions. And on the 6th day or 5th day, when you say E2 levels, it should respond with cervical secretions. No? But we don't look at it that way. Either through ultrasound, you can look at the cervix by withdrawing the probe and looking at the cervix, or put a speculum that validates your ovary, the uterus, and the cervix. That means the basic, like we have the hypothalamus pituitary ovarian axis, we also have ovarian, uterine, cervix. I don't say an axis, but the correlation should be there. The second thing is, why I said learn hyperresponder concept first is, if you are given adequate dose of FS, that means based on the AMH or antral follicles, the age, the body mass index, and when I said ovarian surgery, did they do ovarian drilling for a healthy looking ovary or a classic PCOD with signs of androgen excess? Because we are scarring the ovary. Second thing is, how long was the ovarian surgery if it was done for any ovarian cyst? And how long was it the endometriotic surgery was done, if it was done? All affect the antral follicle count and the perfusion. If you are given adequate dose of FSH, but it should never exceed 300 units. And your follicles are seen and they're growing. By day 4 or day 6, you're unhappy with the rate of follicular growth, and your E2 levels are lower than the ideal values. That means this woman has a suboptimal response to FSH2 ovary. That suboptimal response to FSH2 ovary is corrected by LH supplementation. Because by 4th to 6th day, both granular cell and theca cells develop LH receptors.
So suppose we are giving HMG.
Then what happens?
If we are not giving recombinant FSH or let's say H highly purified, then what do we do?
I would do is as follows, which is unconventional. I would stick to a single provider. Then I would dilute the sample by the sample into 100 ml and then make an alicot and send it to the lab to estimate how much of HCG is there. That way what happens is, you know how much of HCG was topped up for the LH action.
It is just to check the HMG, like concentration of, like checking the vial which we are using. That's
Yes.
what I'll say.
Then I would select the batch which has the lowest HCG content.
Thank you very much, sir. HMG has a big variability. Temperature sensitivity is too much.
And second thing is also estimate because the HMG as per pharmaceutical company should not be measured by should be measured only by the VAT ovarian weight. But you can overcome that by estimating the dilution they have and select that batch. The company will not like it, but don't bother about it. They will say it's a wrong concept, but some concept is better than no concept. That's how I used to use the HMG product. But when you use HMG product, the role of a hyper-responder does not come. The only problem you get is when your product is poor quality, or your cold chain is broken, or too much of HCG is added for LH activity. That's when you have the problem. The role of
Thank you, sir. Thank you, Sharda ma'am. Your last one.
Doctor, last question is on the luteal phase support. I find in Delhi, everybody uses injections, vaginal, Dufaston. What is your say on it?
I use
As a teacher, I've not been able to understand why these people are using three things.
We use only one progesterone, madam. Earlier, we used to use utrogestan at the rate of 600 milligrams. But after the change in the company ownership, we moved into another product where we found the patients were not comfortable, and once Crinone gel has come in, we use one application of Crinone gel. But in the past 2 years, we have moved to 2 applications of Crinone gel. The rationale is it did not increase the pregnancy rate. It only decreased the breakthrough bleeding rate and the anxiety before the negative tests. So in essential, one Crinone gel is adequate, and we have added into the second Crinone gel only to avoid the panicky night calls between the 10th and the 14th day of spotting. That's the reason we are increasing to 2 Crinone gel. Otherwise, one Crinone gel is more than adequate.
Thank you very much, sir. Thank you. Really, the time is very short. Otherwise, there are too many questions. I'll ask one question Dr. Megha has posted. If a patient of low AFC and low AMH and there is a follicular cyst more than 15 to 20 mm on day 2nd, how to treat? Will you suppress the ovary or will you?
I would look at the E2 levels if the UT levels are normal, I wouldn't bother about a cyst. I would consider it's a non-functional cyst. And I wouldn't like to touch that cyst also because I'm going to harm the ovary.
So you'll not suppress and you'll just go ahead. If the E2 levels are less than, what is the cutoff you take?
Like on day 1 or day 2, you might find around, if a poor responder, between 30 to 50 or at the most, not more than 75. Then I wouldn't bother about the cyst. The reason is it's a non-functional cyst. And even if you put the pill, it will not get suppressed if it's a functional cyst.
And second question is on if only one ovary respond. It is many times we see in the stimulation protocol, one ovary respond well and the second ovary is not responding. What is the reason? Is the blood supply to the ovary is a factor?
But some of them I see in case of endometriosis. I think the amount of coagulation we do.
Okay.
Few times I see in ovarian drilling where I find they might have charged it too much, or but these are my speculations.
Thank you very much, sir. I think with this we come to the end. One more question is there. Dr. Anita has asked, when do you do progesterone during a cycle? When you plan fresh transfer? I think sir has answered it already, that he is not doing progesterone level testing in fresh embryo transfer. So am I right, sir?
Yes, because when you look at it, the concept of progesterone elevation has come for many years, and more so it has come with the advent of antagon cycle. The other thing is, we do not stick to the timing of the antagon. Antagon is supposed to be given less than 24 hours between each dosage. And we don't insist the patient to report to us if they got delayed.
That's true. So where we come to the end, I think, and thank you very much, sir. And
It's my pleasure. I'm very happy.
looking forward for the next CME next month. And till that time, I must say thank you, everyone. Thank you, Sharda ma'am. Thank you, all the experts, Dr. Jyoti Bali, Dr. Sunita ma'am, Dr. Jyoti Malik. And I think we are missing Dr. Sharma only. But next time, we are definitely going to see him.
I think next time I'll speak about premature progesterone elevation.
Definitely, sir. Thank you very much.
That makes more appropriate thing.
Yes, sir. That's good. Okay,
Thank
sir.
you, Dr. Seema. Thank you, everyone. Thank you.
Thanks.
Thank you very much.
Thank you. Thank you. Thank you.